Hello, everyone. Hello, hello. Hello, hello. We're waiting for Dr. Manjiri to join. How's your guys' day going? Hello, hello. Give her a minute. Happy Wednesday. Happy Wednesday. So, I haven't gotten NCS results yet. So it's been quite a journey to wait. All right. Nope. You joined the. Hello.
Okay, good. Hi.
Hello.
I realize I should tell children to not knock on the door and come in and mommy me. So I think I missed the key time to get in at that moment.
Okay, great. Don't you worry. Hello, hello, Dr.
Hi.
Manjiri. How are you?
Good to see you. So good
You
to see you.
too. You too. Happy Wednesday.
Yay, we made it. We made
I
it.
know. Welcome, everyone. Welcome, Dr. Manjiri, to an IG Live here on the Brain PT. Today is such an incredible topic because, one, we still believe the spinal cord doesn't have plasticity, or some of us. I include myself before this whole residency uh, journey. So, everyone, this is Dr. Manjiri Dadul. Is that how you pronounce your last name?
You got it.
Dadul?
Yep.
Okay, great. So, she graduated from USC in 2003 with a doctorate in physical therapy. And post graduation, she specialized in neurological rehab at Long Beach Memorial Medical Center and Rancho Los Amigos National Rehab Center. And she was working in the spinal cord injury unit, correct?
Yep.
Great. And she currently serves as an instructor at USC in the biokinesiology and physical therapy department at USC. And she's a certified clinician in LSVT, BIG, and Parkinson's Wellness Recovery, or POWER, for individuals with Parkinson's disease. She acquired specialized training in adaptive equipment, assistive technology, and wheelchair seating positioning as a RENSA certified assistive technology professional. Welcome. What an incredible bio. And I believe she's a co-founder of Precision Rehabilitation in California. Where in California are you located?
We are in Long Beach.
Okay, Long Beach. And you are also director of residency, correct?
Yes, I am. I'm just pausing for a moment because our residencies have been on hold with the pandemic. But yes, for many years we had an awesome residency, and I do see Jamie is on here, so I'm going to say hi, Jamie.
Yay. Hi, Jamie. I hope you remember me. So today we're going to talk about spinal cord plasticity. And synaptic plasticity in the spinal cord has great potential to facilitate recovery of function after spinal cord injury. And before, when I was in school, I would think you got a spinal cord injury, that's it. Like, you're paralyzed, you're not going to get any function back. But guess what? There's a ton of research. Well, and it's starting to come up because there was like less research before, but it's starting to come up that there is the possibility of recovery of function even after complete spinal cord injury. So, and what are those mechanisms that, you know, are behind these changes? So research is now demonstrating that spinal synapses have many of the same plasticity as a brain. I when I learned this, I was like, what? So, but yet, even that we know this, spinal plasticity remains understudied in comparison to our brain plasticity. So today, Dr. Manjiri, she is going to shed some light into this topic and talk to us about spinal cord plasticity. So I'm going to pass the ball on to you and let us learn.
Well, thank you so much for having me. I'm just going to say a quick thank you to Lily because we met a while ago, very briefly, but we really are new friends, new fast friends. And thank you for having me. I've been enjoying working with you and planning and preparing for this. So thank you.
I know, it's so fun.
Yeah, we've been geeking out together this past week, like besties for the past week, getting ready.
Yes.
All right. Well, thank you for everyone joining us. And I know some of you will be catching us for the recording after. But this is a topic that's dear to me, spinal injury, and definitely want to expel these myths that there is no potential for locomotor recovery after spinal injury, and specifically complete spinal injury. So let's just delve right into this. Now, there's so much cool information out there that Lily and I were like, we got to do part 1, part 2. And then the more
we are going to do part 2.
As I was researching more, I'm sure, Lily, you felt this maybe part 3. I don't know. But let's go with part 2 for now. There's just so much fun information. So as you all know, you're familiar with after spinal injury, there's those common upper motor neuron symptoms that you get. Hyperreflexia, muscle atrophy, spasticity, tone, and then there's some very specific ones that happen with spinal injury itself. So autonomic dysreflexia, orthostatic hypotension, motor and sensory impairments, bowel and bladder dysfunction, sexual dysfunction. There's just so much that individuals with spinal cord injury are dealing with. And so our roles as PTs, and I see there's several other of you that are not PTs, but we are geeky neuro PTs. Our job is we want to get as much motor and sensory function and return as possible. We want to help our patients get back to some sense of normalcy, and we're not giving up on them. So that's why we're delving into all of this today. Now, a common question that we get as neuro PTs working in spinal injury is, will I walk again? Will I walk again? Will my son, will my family member walk again? And we need to know the answers to that. We need to have some information, some concrete research studies and clinical studies to be able to help answer that question to our patients. Such an important question. So just as Lily has said, historically with locomotion, we thought that that was not attainable and achievable with a complete SCI. But we're knowing that improvement with training and specifically looking at these complex temporal patterns that we see with that sensory afferent information, that can then translate to stepping and getting back to that primitive reflexive stepping that we see in the spinal cord. So what does that look like? Now, before we get into that, I want to share with you, I think, one of the most mind-blowing little tidbits that I relearned when I was researching again, that 61% of individuals who are clinically diagnosed as a complete SCI are actually technically, anatomically, an incomplete SCI.
Oh my God.
Big.
That just gave me chills.
I know, right, Lily? Like 61%. You think, okay, you have an Asia A, or I hear, you know, you're a complete SCI. No, 61% of them are technically incomplete. And that is just so heartwarming because those axons are regenerating. So there is hope. There is absolutely hope. The spinal cord is plastic. Yay.
Yes.
Okay, so just like Lily said, and I'm looking at all her brains behind her, and I know she's the brain PT, but I think you need a spinal cord back there.
I know,
Maybe,
I
maybe after
do.
part 2, I'll gift you a spinal cord.
Oh, yes. I'll
So
put it right here.
there, that's a perfect spot
I
for
need
it.
a reorganized all here.
I love the brain. I love the brain, but I'm feeling like we need a little spinal cord back there.
Yep.
So
Mm-hmm.
just as we know all of that research out there about brain's plasticity, it's the same within the spinal cord, right? So what
Mm-hmm.
is neuroplasticity of the spinal cord? It's just like the brain. It's reorganization of a given region, for today's topic, spinal cord, and or changes in a specific area related to function. And today we're talking about locomotor function. Okay, so just like within the brain. So what exactly is happening in the spinal cord? Like, how are we getting neuroplasticity in the spinal cord? We know about cortical remapping, we know about the homunculus within the brain, but what's happening right there within our spinal cord? So there's some theories. Some of them are saying that there could be parallel pathways of activation. So there's all these different pathways occurring that you all are familiar with, those neuronal networks, parallel pathways that are being activated. We could be unmasking silent neurons or pathways that we thought were dormant. They were complete injury. They were completely severed, but now we're unmasking them. And then also we're forming new pathways and new circuitries. What do you think about that?
The most amazing thing from all those three, I think it's the unmasking the silent pathways. Like, just like, bloop, you know, wake up, and then everything starts. Because this happens also in the brain when we're talking about like after injury. And, those unmasking those silent pathways are, the synapses, it's just great because that's where like the doors for relearning, it's like the starting point, because those obviously those new neurons that are woken up, they just woke up, are going to help those other neurons around that are still healthy. So I think from all those points, I love the unmasking the silent ones. And I still remember this concept when I was studying for NCS. I was like, wow, like I would just think about those synapses kind of like, oh, but yeah, it's amazing.
Yeah, I know. It's just like we know this in the brain, but it's happening in the spinal cord as well.
Yeah.
All right, so we're talking about unmasking these pathways and neuronal networks. So what is so important is the lumbar spine, okay? The lumbar spine is the key within the spinal cord, right? You can have an injury in the cervical, in the thoracic, in the lumbar spine. It could be upper motor neuron or lower motor neuron if the cauda equina is affected. But that lumbar spine we're finding is key to trying to help locomotor back.
Oh.
Lumbar spine. Why?
So
Does anyone...
why is that?
We have some smart people on this live. I'm wondering if anyone wants to throw a little something out.
Somebody has an idea why lumbar is important? I don't know. Let's see who is brave and can. Let me see who's on.
If not, we've got some answers. I won't call out anyone. Not this time.
She's
Maybe
faculty,
next time.
so yeah.
Anyone? What are you thinking?
So this is where my brain's going.
Okay.
So we have the end of the spinal cord in the lumbar spine, which is about like what, L2. Is it because like your nerves that go to your like legs are in the lumbar spine, or is it because I don't know. That's where my brain's going, but I don't know the answer.
Okay, great.
That's my educational guess.
Okay, you're definitely onto something. So the lumbar spine innervates lower extremity musculature, and I knew she would nail this. One of our smarty pants on here is telling us about CPGs are located within the lumbosacral region, and they assist with hip flexion. So nice job. I knew you could do it. So yeah,
Oh, sorry, go
No,
ahead.
no, 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 no. Go ahead,
I
Lily.
was just going to say, so for people here, what are CPGs?
Oh, CPGs. Okay. So we're going to get into those details. Pause for a quick second because I want to make sure that we can talk a little bit more about the lumbar spine and why it's the key. So we're
Okay.
talking about this CPG. I'm going to tell you more about that. But what's important in the lumbar spine is if there's inflammation within that lumbar spine. So let's say you have an injury specifically at L2, L4, somewhere within the lumbar spine, that inflammation is going to lead to potentially maladaptive relearning. So our bodies are not going to be able to relearn how to step and have locomotion, since that's a key area of these reflexes. Also, what's important to note is that inflammation from your actual location of injury, whether that's a burst fracture or what am I trying to think of? Or stretching of some key nerves or blood vessels, wherever that initial injury is, you can have inflammation up to 10 segments away. That's a lot. That's huge.
Okay, so, okay.
So it's
Wow.
expanded here. So even if you have an injury in the lower T-spine, and let's say 10 segments down or 5 segments down, you've got some swelling down into the lumbar spine, that can also be maladaptive for locomotor training and re-stepping. So that lumbar spine is key. We've mentioned CPGs. So what are CPGs? Us PTs just throw that term around like it's so easy and that it's nothing. So
There's not CPGs, clinical practice guidelines, guys,
oh,
because that's
that's
where my brain goes
true.
when I hear CPGs.
Oh,
This is
that's true.
something
That's
even,
right.
this is something very, I will call it amazing.
CPGs are pretty amazing. So for today's topic, the CPGs we're talking about are central pattern generators, okay? CPG, central pattern generators. And essentially, it's a reflexive pattern that can be produced, and it's within the lumbar spine, lumbosacral region. And with that activation of CPGs, you're able to incite a reflexive stepping motion within the body. And there's all kinds of research out there on cats and adults. So different types of animal studies is really where a lot of this research is. They're doing some work on humans as well, but essentially these some of these cats have had this complete spinal cord injury. They've had everything severed, but these CPGs, along with other afferent input, can help lead to locomotor rhythmic re-stepping again,
Wow.
which is super fascinating. Like, what? They're not flaccid? That's it? No. The body is plastic. We can regenerate. So these specific pathways in mammals are still pretty obscure. Dr. Harkema is a huge researcher in spinal injury, and I'm always just following anything I can to learn more. And there was a recent article from her in 2021, actually, that said, although we know about these CPGs in mammalians, it's still a little bit obscure. So we're still learning, but we can see this. We can see in our patients when we, and this is a little bit more part two, but when we get that hip extension, we can see
Terminal stance.
rapid hip flexion. We can see rapid
Yeah,
hip
it's
flexion.
that
We can see
trick.
that
Yeah.
reflexive motion. So I love the CPGs. They're awesome.
Wow. So that's why it's important. This is what comes to my mind. Bringing those patients to your terminal stance and stretching those hip flexors so they can, come all the way back into that terminal stance and tap into those CPGs.
They got to have the range, so that hip extension is huge, just like you said.
Yep. Yeah.
Awesome. So that's the CPGs. We could go on and on and on about them and do a part
Part
5.
two.
Part 2. Yeah, part 2.
Yeah. Okay. It's amazing.
Anything else about CPGs? Are we ready to keep going?
No. Ready to keep going.
All right. Awesome. All right, so this is another fun topic. I love how Lily just jumped on this week. She's like, adaptive versus maladaptive neuroplasticity. Like, mind blowing. Yes, you can have maladaptive neuroplasticity. So we always think like, we're driving neuroplasticity, everything's so great, we're reps and intensity and all of those great principles that we know, but there is something called maladaptive neuroplasticity.
So how does that look like in spinal cord injury? Because I know in stroke, maladaptive could be when they're learning, let's say, upper extremity movement and they haven't had a ton of intensive rehab. They learn to compensate a lot with their traps, and it looks a lot like this, and they learn that movement. How does it look like in spinal cord injury?
So maladaptive plasticity and spinal injury can be very similar. So whatever
Mm,
impairments patient presents with, if they're not learning that normal locomotor rhythmic stepping pattern,
mm-hmm,
then let's say they have flat, significant paralysis and weakness, and they don't have enough quad strength. So their knee
mm-hmm,
goes into hyperextension during scans,
mm-hmm,
and they're not able to keep a little bit of a knee flexion.
mm-hmm,
Or same thing, maybe the hip flexors are weak and they're circumducting, or they're using a
mm-hmm.
trunk lean to get their hip up versus
Okay, so very.
retraining our patients. Yeah.
Mm.
And even with significant tone and spasticity, they're not getting enough knee extension. Maybe that hamstring has too much spasticity and they're just not getting that normal pattern.
Mm-hmm.
So, and then obviously adaptive plasticity is promoting recovery. So that's what we strive for. That's what we aim for, really getting recovery, not compensation. And then we want
Mm-hmm.
to have true plasticity and getting remapping and reorganization the way that we want to see it so we can have that normal pattern.
Wow, amazing. So I have a thought, and I just realized that I was thinking about this as you were saying, the gait training. Because when we think spinal cord injury, a lot of, like, my mind, I'm going to talk personally, because I don't want to generalize. I think about someone in a wheelchair, but not all the spinal cord injuries are like this. You will be surprised, in general, you guys, how many people with spinal cord injury can actually walk. So I have to be reminding myself, like, don't think about spinal cord in a wheelchair. Like, no, I need to be thinking about, uh, yeah. So that's like a little, bad job.
Well, it's not a bad job. You
Yeah.
mentioned you don't see spinal injury
I
as
don't see much a lot. Mm-hmm. Yeah.
so I see a lot of it, and I just look at
Mm-hmm.
spinal injury as a spectrum. So you say,
Mm-hmm.
okay, they're not
Yeah.
always in a wheelchair, but some patients are like they have a combo. So maybe for community ambulation, they need a wheelchair because they can't
Perhaps.
walk as far, or their
Mm-hmm.
endurance isn't great, but they walk around their home.
Mm-hmm. Yeah.
Or they walk with one assistive device at one time or another, or bracing.
Mm-hmm.
But
Mm-hmm.
a lot of individuals have an incomplete spinal cord injury and they're walking. A
Mm-hmm.
lot of,
Yeah.
I'd
Yeah.
say over 50% of my patients with SCI, they're walking.
Mm-hmm. Yeah.
And some without any assistive devices. So it really
That's
just is a
amazing.
spectrum and it depends.
Mm-hmm. That's amazing. Yeah.
All right, so our intervention choices matter. We're going to talk a lot more about that in part two. Part two is going to be how do you drive that intensity? What does locomotor look like? How many
Mm-hmm.
sets and reps and timing and all that good stuff?
Mm-hmm.
But just a little plug, because this is what we do, that intervention choices matter. Like even today in the clinic, I was with someone and I said, well, I better stick on that E-stem and get them on the treadmill so I can get my reps and get my E-stem. And I've got to drive all these sets. Like we can't just do some little walking over ground unless I'm really pushing it and driving it. So
Yeah.
that
Yeah.
intervention choice is really, really important in spinal injury, just like with all of our other patients.
Mm-hmm. Yeah. Yeah. I have another
So,
comment, but I don't want to lengthen this video, but it's just so many good things to say in general, but we'll save it for our next part two.
okay, all right. I think we're doing pretty good, but let's see. Hold that thought, Lily.
Okay.
I was going to briefly go over the principles of neuroplasticity. Many of you might be
Great.
already familiar with it.
Mm-hmm.
I was scoping out Lily's Instagram page and saw she did a whole couple segments on neuroplasticity. And so I won't bore you with all the details, but I think a review is always good. And then I'll just touch up on a couple important ones here related to spinal injury. But I do see we have a
Yeah.
question here.
Mm-hmm.
Let's see.
So from an inpatient rehab standpoint, since we see them right after the acute injury, how can we predict that they will be able to ambulate so we can train them appropriately from the beginning?
Okay, that's a great
That's a
question.
really good question. Yeah.
So I'm an outpatient rehab, but I have done inpatient acute spinal injury. So let me make sure I answer your question properly here. Since we see them right after, how can we predict? So what's interesting about that is we can't predict. We don't know. Even if someone has a complete injury in inpatient rehab, that is not going to predict what their potential functional outcome is. But we can drive that change. So you training them appropriately is going to be huge so early on. And even a lot of this is mental. Like this could be a whole nother segue, but even having patients mentally telling them, like, you can do this. You have the potential for more recovery. We don't know exactly what it could look like, but with a joint effort, there could be change. So I'd say there are some articles out there that can tell you how to help predict what the outcome could look like, but with right intensity, driving these neuroplasticity principles, and then definitely catch us for part 2 on the specifics of what your training session should look like. That's going to help you train your patients appropriately from the beginning. Now, there's so many other comorbidities and issues in inpatient rehab. So oftentimes I found when I was in acute rehab, sometimes just mentally, psychologically dealing with the injury was very challenging. So then to try to like drive this neuroplasticity and locomotor training intensity, you know, we're restricted by visit numbers and how much we can keep our patients in here. It's almost like, let's just quickly discharge home. They're safe, they're good. So there's a lot of things happening very quickly, but I would say just keep the hope and the faith, push and challenge as much as you can. But we do know early on, there's a lot of inflammation within the spinal cord. So it is important that you're training properly. If not, it could lead to maladaptive locomotor training. So I hope that kind of answered your question, but definitely check us out for part 2, because we're going to go over all the studies of locomotor training, and there is some acute studies. I'll make sure I get to look up a couple more.
And there are 2 articles that are very helpful. One by Tacola that's called "And Yet It Moves: Control After Spinal Cord Injury." And this article talks about how the return can occur in the first 3 months after the lesion, but then it continues up for a year, up to 1 year, and occasionally even longer. And there's another article, really good article, that's called "Who is Going to Walk?" And this reviews the factors that influence walking recovery after spinal cord injury, which I can put those articles in the caption after the IG Live so you can check them out.
Okay, great. Awesome.
Yeah, those are good articles.
So much fun information.
I know. Oh. Anyways,
I definitely add a couple ones here too.
Yeah.
I definitely would like to see these article links. It's a library.
Yes, I will put the names, and you just search and then put PDF at the end of the title, and then Google should present to you the article.
Yay. All right, so let's quickly touch up on those principles of neuroplasticity, and then we'll get into just a couple specifics about spinal injury. So as you all know, and Lily's done an awesome job in presenting those main principles of neuroplasticity, we all know some of the top ones like task specificity, repetition, intensity, salience, time, age, transference, and interference. Okay, so we'll just go over a couple of them. I know you all know most likely task specificity, but gosh, that's so important. We have to say walking is walking. If you want to improve locomotor training, it has got to be locomotor training. There's research. We talked about Harkema and Egerton talking about standing versus stepping. And those research articles pretty much said if you want to improve stepping and locomotor training, it has to be stepping and locomotor training. Not even standing. Standing is not enough to get that locomotor training back. Repetition. So you know this, Lily. So much. Boyd and Carey says you need at least 1,200 reps to drive brain plasticity. Well, surprise, the spinal injury is really no different. The spinal cord is pretty much the same. Research shows you need at least 1,000 reps 1,000, so that's a lot, to improve normal stepping kinematics and patterns versus there's some research on just 100 steps. So just pause for a moment. Think about you're in the clinic and you've got to drive neuroplasticity, and that means 1,000 reps for locomotor training. So that's when I'm really big on some type of body weight support system. We have the light gait at Precision. I love it. Do our best to not unweight patients too much because they really need that weight bearing and that sensory input that's important. But at least the harness is there for safety and stability. And then obviously it just depends on your patient and how much they need. But 1,000 reps, that's important. So even that inpatient question we have there, think about that. 1,000 reps to really get normal stepping kinematics and patterns. We all know a lot about intensity, so we don't need to spend too much time on that. But does anyone want to throw out like a couple ways with locomotor training to improve intensity? How can we drive that intensity with locomotor training? Throw something at us.
Let's see.
It's a warm one today. I'm sweating.
Me too.
Well, I'm in Long Beach. It's cool. I guess you should
I'm
be really
in Texas.
sweating in Texas.
It's like 100.
Sorry, I shouldn't have said anything. It's probably only 80 here.
It's okay.
All right, anyone? How to drive intensity with locomotor training? What do you think?
Let's see what.
All right, well, for time's sake, I'm going to throw out a couple and then we'll get into this more. But obviously, depending on the amount of weighting and unweighting in the harness, you can do dual task, increase time, duration, velocity, obstacles, assist levels, right?
Speed,
We're
heart
there.
rate. Yep, there we go.
Speed, heart rate. Good. Woo!
Ooh,
Oh,
polar watch.
We love the polar watch. 65 to 85% max heart rate.
Nice.
Loving it. That's exactly what we need to do. I'm not going to spend too much time on salience or time. Age is a whole nother factor, young versus older adults. And I think those were kind of some of the main ones that I wanted to go over, really talking about that repetition and how the high reps are just as important in the spinal cord. But I want to make sure I respect everyone's time and Lily's time.
So I wanted to come back to that thought about intensity.
Oh, yeah.
Just today I was working with a patient who had a stroke and in the rehab, acute rehab, and he is super high level, so he should be discharging soon. He progressed way faster than what we anticipated. And today I wanted to, he walks like with mod eye. He does have a little bit of that very, very slight hemiplegic gait. He does have profound upper extremity weakness. And I know this is switching topics to stroke, but this is about intensity. Today I decided to work on those little things about his gait that he's missing. He has quite some plantar flexor weakness, hip stability not there, completely hip abductors, glutes missing. So I had him do quite some high intensity workouts. So we even practiced jumping. So I got him really like, I was even hot. I was not even doing anything. I was like, oh my God, I don't know why I'm hot, but this is intense for me too. And, we were doing assisted lunges. So it's different type of high intensity because this is not aerobic intensity, but he said it was quite intense for him. And I was a little afraid because this is acute rehab and usually you do this in outpatient, but I was pushing that intensity, adding weight into his repetitions and focusing on higher reps. On that power and smooth landing on the jump. So pushing that high intensity and very, very surprising. I mean, maybe it was just my brain was very excited, but his gait, I don't know if it was because we worked a lot in mobility as well during the session. His gait looked a little bit better after the session, and I was like, what? So maybe it was just my brain was excited, but that high intensity, don't be afraid of pushing them. If it's too easy, their brain will be bored or their spinal cord will be bored. Now, since we're talking about spinal cord,
Yeah.
but I know sometimes, because I feel this, I am afraid of pushing them, especially aerobic intensity, because we're like, it's acute rehab. Sometimes they can get sick in like this minute. So, but don't be afraid, because the research is out there. So intensity, 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 push that intensity. There's many ways to push intensity. So that was my thought about, I was very excited because I had him jumping.
Yay.
Yeah, so work on that power. Mm-hmm.
I love it. I think that intensity is so important. And
Mm-hmm.
I know what you're saying. In acute rehab, you might feel a little nervous, but
Yeah.
you know, you're monitoring your patient, you're looking at their vitals, you're
Mm-hmm.
looking at the patient, getting their RPEs, giving them rest breaks as
Right.
needed, or
Right.
maybe building up and in one session working at 65% max heart rate, then the next session you bump it up to 70, 75. So, you know, you don't have to go like 85 day one, and you're
Mm-hmm.
slowly building up and using your clinical judgment so that you're
Mm-hmm.
safe, but driving that neuroplasticity.
Yeah. Yeah. So, oh my gosh, this was so amazing, and I'm sure everyone enjoyed it as much as I did. Thank you so much for bringing all this knowledge today. I really hope you guys enjoyed this video. Thank you for coming, Dr.
Thank you for
Manjiri. It was amazing. We have a comment. I love jumping. Modified squat jumps. Yes, yes, amazing. But I cannot wait for part 2. It's going to be so fun. And I just feel like everything that I can learn about spinal cord injury right now, I am like a sponge because I have no experience. So if someone comes in with a spinal cord injury, I want to feel ready, because sometimes I feel like, But thank you so much for joining us.
My pleasure. Thank you for having me. And you've got this if you get a patient with spinal cord injury and you got a friend to help you out too.
Oh, thank you so much. So guys, thank you for coming. Part 2, we will be releasing the date soon. We're going to talk about locomotor training, how to start so you can feel ready and confident to start that walking training with your patients. So thank you guys for coming, and I hope you have a great rest of your day. Thank you so much for
Thank
coming.
you for joining us.
Bye, guys.
Bye.